Okay. Hi, everyone. My name is Nellie Figani, and it's my privilege to extend a heartfelt welcome to each and every one of you joining us here in person or virtually. Before we begin, I would like to take a moment to acknowledge that the land we are meeting on today is in the traditional territory of the Anishinaabe, Huron-Wendat, Chippewa, Haudenosaunee, and the Mississauga of the Credit First Nation. This land is covered by Treaty 13, which was signed by the Mississauga of the Credit, and the Williams Treaties, which were signed with multiple Mississauga and Chippewa bends. If you are a settler on this land you reside, I would encourage you to take some time to learn more about the history of the land and to reflect on how we can each, in our own way, be active participants in this journey to reconciliation. I would also encourage you to seek out Indigenous-led events that will be happening this week for the National Day for Truth and Reconciliation. It is also important to acknowledge the ongoing impact of colonialism on Indigenous peoples and the systemic racism intertwined in the healthcare system. As a health-focused organization, TENSI is committed to move forward in a spirit of reconciliation and collaboration. We all have the responsibility to honor and respect the four directions: land, waters, plants, animals, ancestors that walked before us, and all the wonderful elements of creation that exist. On behalf of both the International Continence Society, ICS, and the Endometriosis Network of Canada, I'm thrilled to open our doors to this unique and collaborative event today. The ICS is a registered charity with a global health focus dedicated to enhancing the lives of individuals affected by urinary, bowel, and pelvic floor disorders. Through education, research, and advocacy, we strive to advance pure, applied, and clinical science in this field. Each year, our annual meeting brings together a diverse group of healthcare professionals from across the globe. This year, Dr. Lemos and I have the distinct honor of being part of the local organizing committee here in Toronto, Canada. In addition to my role with ICS, I have the privilege of volunteering on the board of directors for the Endometriosis Network of Canada. TENSI's unwavering commitment is to build a strong, informed, inclusive, and compassionate community. We do this by providing support and education resources for all those affected by endometriosis across Canada, while we also raise global awareness about this condition. At the heart of our work lies the patient community, the driving force behind our mission. Today, we are exceptionally excited to present a co-branded event by ICS and TENSI combining forces for this patient education symposium at the 53rd annual meeting of the ICS. This interactive program is a unique opportunity for individuals with endometriosis and/or pelvic pain, healthcare providers, and scientific researchers to come together as a united community. We will delve into the various causes of symptoms, ranging from bladder and bowel issues to nerve-related concerns, and explore the multifaceted factors contributing to pelvic pain. The agenda includes esteemed speakers from diverse medical specialties, as well as individuals who will bravely share their personal journeys and perspectives living with endometriosis. It is with great excitement that I extend a warm welcome to each and every one of you for our session titled Exploring Endometriosis and Pelvic Pain from Science to Solutions, a symposium tailored for individuals with endometriosis and those who support them. So welcome.
Okay, I'm going to introduce our first speaker. Please welcome Skylar Hammond. They, them, one of the many endo ambassadors who's very excited and honored to be able to work with TENSI, an organization that is very close to their heart. Please welcome Skylar.
Better go a bit closer. So, as you know, hi, my name is Skylar Hammond. I'm 27 years old, and I use they, them pronouns. I'm a proud member of TENSI Endo Ambassador Program. So, my journey was slow. It takes about 3 years. My life has been a stage of waiting rooms, doctor's offices, operating tables. When I was 15 when I got on my first birth control, after years of excruciating pain, nausea, and missed school. This will make everything better, he said. It did not make anything better. In fact, it made things actually worse. I suddenly went from being in pain only during my periods to pain every single moment of my life, to being unable to exercise, to eat normal-sized foods, to having fun with friends. Back to the waiting room. Here, let's try this one, or this one, or better yet, let's try this one. By the time I was 20, I'd been through about 16 different types of birth control. My family doctor gave up. I don't know what to do, he said, handing me a slip of paper for a GYN. They'll be able to help you. Back to another waiting room. I nervously told her I was trans. I don't work with trans people, but I'll do the laparoscopy anyways. But first, let's try an IUD. She tried to insert it while I was awake. I passed out due to the excruciating pain. Fine, I'll insert it during surgery. Slowly and painfully waking up. Congratulations, I didn't find anything. Heartbreak, confusion, frustration. Back to square one. Try this medication, or this one, or this one. Sorry, I lost track of where I was. Nothing worked. The GYN let me go. Try a naturopath, physical therapy, pelvic floor therapy. Pelvic floor worked for a while, but again, sadly, it got a little bit too expensive. Back to the family doctors, back to the waiting room. Here, he shoved another GYN, endocrinologist, and gastrologist at me. The GYN, I strongly suggest the GYN saying, let's do another laparoscopy. Let's see if they missed something the last time. Again, nothing was found. Let go again from this GYN. Sorry, there's nothing else we can do. Your case is just a little bit too complicated. The endocrinologist's waiting room was long for a few seconds meeting. There's nothing wrong with your thyroid. Have you ever considered the shocking revelation of maybe just stopping worrying about it? Yes, let's stop worrying about the constant pain, the constant nausea, and how I can't have a normal life that I was taught I was supposed to have as a 24-year-old. The gastrologist's waiting room was short, and the colonoscopy/endoscopy was even shorter. I explained all my gas pains, the bloating, the nausea. The gas bubble was so bad that I appeared pregnant and caused me to lay down agony and vomiting. Nothing. Absolutely nothing. The GYN laparoscopy also came empty. Let go from them. Just get a job. Just get over it. An endo specialist was my last shot. After a painful internal exam, which I barely made it through, he said he also found nothing. It's probably hidden somewhere in your body, he said. There isn't much else I can do. Normal waiting rooms for me because there was no one else willing to help me. Instead, I focus on finding distractions and support. I find it in my supportive family and in volunteerism. They don't fully make me forget about the pain, but it's nice to have people who care. But finally, I found one medical thing that kind of works. Medical cannabis, not cannibalism. Is it a cure? No. Does it help me? Most of the times. Is it expensive? Yes, definitely. My pain is so normal for me, it's almost like a companion. I still can't do much. My fatigue is not letting me experience the life I was told I was going to experience as a 27-year-old. If I could tell a person dealing with endometriosis or pelvic pain anything, it would be this. Hold on. The pain will end. You will have better days. And for all the trans people with endometriosis, I see you. I see you in your pain. You're not forgotten. We will get through this, and things will get better. Thank you.
Thank you so much, Skylar. And now I'm going to introduce our next patient speaker. It's my pleasure to introduce Kim Harris. Kim has been an avid community volunteer for as long as she can remember, particularly with causes that hit close to home. After being diagnosed with endometriosis at the age of 50, Kim was shocked and surprised at this news. Originally from Toronto, Kim grew up in Halifax and became a Westerner almost 10 years ago. Please welcome Kim.
Good evening, everyone. My name is Kim Harris. My pronouns are she, her, and I'm a volunteer with 10C as an endo ambassador. I'm joining you all tonight from Saskatoon, which I am now calling home. Just want to thank you for your time and the ability to share my story. As mentioned, I was diagnosed with endometriosis at the age of 50, following treatment I had chosen to engage with an HRT, and that was directly related to my my menopause symptoms. I did my research, checked facts, and spoke with others who had chosen HRT as a way to cope. After weighing the risk versus reward, I did decide to start using HRT. After a few months of treatment, I began having heavy periods again and some mild to severe abdominal cramping. This had happened intermittently over the next year, and while in Saskatoon on a house hunting trip 2 summers ago, I ended up, unfortunately, in the city hospital with severe abdominal pain. This visit resulted in exploratory tests for ovarian cancer, which was incredibly unnerving for myself and my immediate family. I was then seen by an OB/GYN here in Saskatoon who confidently diagnosed me with endometriosis. To say I was shocked was an absolute understatement. I am the parent of 2 beautiful twin girls who are almost 21 now. I had had no issues whatsoever in getting pregnant, and I'm a little embarrassed to say that at that time, that was really the only thing I understood about endo, and that it caused fertility problems. I was then put on medication to shrink the tissues and manage my pain. This worked and kept my symptoms manageable for the next, I'd say 10, 11 months. In March of this year, I ended up again in the ER. I was quickly informed that the blood supply to one of my ovaries was cut off and I would require immediate surgical intervention. Again, taken completely aback. The removal of my ovaries ended up as a full hysterectomy and the removal of all my reproductive organs as a precaution, given my age, and to prevent any future or possible cancer diagnoses. Following my surgery, I was still somewhat in shock and felt that I really could not be the only person out there dealing with endo at this age. In an attempt to bring attention to endo and HRT, I wondered about sharing my story on social media. And I'm actually a very private person as I'm here sharing my story publicly with you all. And I sent a draft of what I had written to my daughters for their opinion. They in turn pointed me to Bindi Irwin on Instagram. Some of you will remember the crocodile fella, Steve Irwin, that's his daughter. And she has publicly shared her trials and successes with endometriosis. I think you might have lost me there. Seeing her profile and link to endo support in Australia led me to find 10C here in Canada. I decided to get involved and was honored to be accepted as an endo ambassador earlier this year. Looking back, 80s, early 90s, and the stigma around mental health, addictions, and other of those typically not discussed medical conditions, I now recognize the critical importance of being vocal on endometriosis, its existence, its reality, and the challenges that happen with this condition. And the fact that conversations really need to happen with regards to endo. I now think back to my 14-year-old self being put on birth control like Skylar, told to take Tylenol and manage my ongoing discomfort as it was just part of being a woman. And while that still may be unfortunately true, more attention to this disease must happen for the thousands of us that have dealt with and continue to deal with endometriosis. It's a real condition, has its own set of challenges and hurdles to navigate, and we simply need to do better. I thank you very much for your time, attention, and letting me share.
Thank you so much, Kim. Next up, I'm going to be introducing Dr. Elise Day. Dr. Elise Day specializes in female pelvic medicine and reconstructive surgery, urogynecology, neurourology within the Department of Urology at Albany Medical Center in Albany, New York. Please welcome Dr. Day.
Thank you so much for having me. My name is Elise Day, and I think this is the first time we've had a patient and community session at ICS ever. Or at least in my recollection since joining. And I'm really pleased that we can do this. I hope we can do more of it over the years with, the conditions we treat. And I do have disclosures. My disclosures are Labrie Medical Technologies, Flume Catheters, Luca Biologics, Alight, Ironwood Pharmaceuticals, Glycologics, Cambridge Medical Experts, Legal Med, ERYP, and Doximity. You'd think I'd be rich, but I'm not. So this is a typical case. I might see someone who's 32 years old, and not only is there a history of endometriosis, which I don't treat directly, but irritable bowel syndrome, no surgery yet, maybe some urinary urgency, frequency, pelvic pressure, sensation of incomplete bladder emptying, but the bladder is empty, and pain with intercourse. And this represents maybe a more simple history in the spectrum of people who come to my clinic. And so, additional disclosure, I'm a stone turner. So I like finding the cause of the pain. And it's not always possible, so it can be frustrating. But when I was younger and earlier in my practice, I would go to lectures and try to learn about pain, and so I could bring it back and help my patients. And I'd go to these lectures, and they'd sort of like define these syndromes and the medications that help bladder pain syndrome. And I felt like I didn't. It's really hard when you're standing in front of someone with pain who's asking you for help and you feel that you don't have what they need to offer them. It's a very uncomfortable dynamic. And so I just kept trying, and in fact, many of us have contributed to a book that is a stone-turning book. It's called Facing Pelvic Pain, and there's a website, .org, associated with the same book. And so it's a book full of stone turning, and it also pays heed to the fact that while we're turning over stones to see if we can find a cause, we also want to treat the person as a whole person and the pain and their context, and also give plans and backup plans if you don't find a cause. So this is what this group is about, is the plan, the backup plan, so that people aren't just stuck out there on a desert island. So these are the bladder and bowel things that I chose to talk about today that can lead to pain. It's also really important to distinguish, is it localized to the pelvis, or is there multi-system pain throughout the body? So this is a urethral diverticulum, and is there a pointer? Okay, thank you. So this is the urethral diverticulum. So this is a urethra. This is a person sliced this way. And the white around the urethra is a collection of urine. So it's like a little balloon with a connection to the urethra. And the history can give us a clue if somebody has post-void dribbling, recurrent urinary tract infections, and pain with intercourse. So we look for that in the history. It has to be diagnosed by MRI, typically, or ultrasound. This is a stone in a urethral diverticulum. That's rare. That's a cystoscopic view of the urethra. And another thing that can cause bladder and urethral pain is something called bladder outlet obstruction. So how many people have had a urodynamics test in this room? It's a little intimidating, right? You have pain and you go in where someone's going to put a catheter in that urethra. Most people, even my patients with pain, say it's not as bad as they expected. And we can get people through that test with taking Tylenol prior and bringing phenazopyridine, which is pyridium or azo, to the test for afterwards. And you can see here, this person has a bladder contraction, and this is a very strong bladder contraction, and the bladder's blocked. So as soon as we make a diagnosis like this is no longer interstitial cystitis, this is bladder outlet obstruction. So it's a cause that we can treat. Urethral pain can also be caused by ureaplasma, mycoplasma infection, vulvar atrophy, turbulent flow, and some neuropathies, as well as nerve entrapment. A stone trapped at the distal ureter close to the bladder. If somebody has acute onset of pain, which I know it probably doesn't describe many people in this room, and is one-sided pain, a stone can lead to pain. Typically, it's going to localize to one side or the other. And I'm sure that some have had chronic pelvic pain plus a stone, which is a really adding acuity to the situation. Sometimes we'll recommend doing a cystoscopy. Cystoscopy is another procedure that's fairly intimidating. Again, Tylenol prior, phenazopyridine afterwards can be helpful. I do see this procedure being pretty uncomfortable for some of my patients with chronic pain, but it does sometimes lead to a helpful diagnosis as well, or at least a rule out if we're worried about some of the more dangerous things. And this talk is about the connection between the bladder and the bowel. And I really love this image. These are the nerves that go through the pelvis. And here is the innervation along the side of the rectum. And this is called the inferior hypogastric plexus. This is a mix of sympathetic and parasympathetic nerves, the autonomic nerves. And they're also the nerves that cause like cramping and nausea and that faint feeling when you're having pain. And then you can see that these nerves are going onto the bladder, and they're also involved in sexual function. And they can be disrupted during surgery, or they can have dysfunction all on their own when the nerve health is not good. They're also very reactive to your levels of stress and overall experiences of stress and trauma throughout life. So when there have been good studies in animals showing that there's crosstalk along these nerves. So if you inject something in one part of this innervation, it will demonstrate that there is cross-innervation from the bladder to the bowel, etc. Also, there's cross-innervation involving the pelvic floor muscles, which is Nellie Fagani's specialty. So we can see sources of anal pain, and this can be related to constipation. And so one thing to consider when we're addressing endometriosis pain is how many other layers of pain are there stimulating those nerves. So if somebody has like an anal fissure or constipation or a high tone pelvic floor that's leading to bowel dysfunction, it's going to sort of amp up all of the other nerves talking to each other. And so we try to address all those layers at once. And there, of course, can be internal causes of pain like diverticulitis or irritable bowel syndrome or Crohn's disease, ulcerative colitis, etc. And irritable bowel syndrome is really very interesting because it has its own innervation that can there's like a very strong mind-body connection to the innervation of the bowel. So this is a tool that is at the website facingpelvicpain.org, and it's like a little checklist of local versus systemic pain. It also provides a checklist of things people have tried before and testing that they've had. And we put this together to just help people gain a little bit of control over all those visits to the waiting room and all the testing, all the stones that have been turned. And so people can follow their path, and when they're ready to turn stones again, they can go back and see where they left off and use these tools to communicate with the providers on the other side of that waiting room. Thank you.
Thank you so much, Dr. Day. Next up, we have Nellie Figani. Nellie graduated from the University of Toronto Physiotherapy Program in 1996 and has been exclusively treating pelvic dysfunction since 1998. She currently co-owns and operates 7 physiotherapy clinics in Toronto, Ontario, Canada, and is an ongoing mentor to many physiotherapists. Please welcome Nellie.
Thank you. Thank you. Yeah, so the title of my talk is What Do Your Pelvic Floor Muscles Have to Do with It? So as a physiotherapist, I treat pelvic dysfunction, and there's a lot of evidence that shows effective treatment for various types of pelvic dysfunction, including incontinence, prolapse, and even pelvic pain. As a physiotherapist, we require some postgraduate training to learn how to do the internal exams and learn the conditions that we treat for this. So if you're looking for a physiotherapist and you're inspired after this talk, make sure that you look for someone that has the right training. And I just want to give you an idea of what's involved if you go for an assessment, and then we'll get to the pelvic floor as well. So when you come in, we do a very thorough subjective evaluation, meaning taking your history, hearing your story, what surgeries have you tried, how are they effective, what medications have you taken, what has worked, what hasn't. We ask a lot of questions regarding your bladder health. So how often you go to the bathroom, do you have urgency or frequency, do you have pain when you're urinating, do you need to strain? It's really important for us to know exactly what symptoms you're experiencing so that we can look at what your goals are. We're kind of obsessed about the bowels, I'm not gonna lie. We want to know how often you poop, what does it look like, what position are you in? Again, is there any pain associated with it? Getting to those goals that we have that can help the symptoms that you experience. We do ask a lot of personal questions, and you get to answer the ones that you're comfortable with, but they're all relevant to what your goals are again. Questions around your sexual activity, what can hurt, where does it hurt? How long has that been happening? Because we're looking for that history. Has it always been like that? Is it because of hormonal changes after you've had surgery or certain life events? Other musculoskeletal things that could be contributing to your pain. Of course, we ask a lot of questions about your pain as well. That's really important. We want to know where it is, how long it's been there, what makes it worse, what makes it better. We also give a lot of questionnaires out often because we want to look at you as a whole person. So that biopsychosocial approach is the way that we go. So the bio is the tissue piece, and the psychosocial pieces can be captured through various types of questionnaires that have been validated in the research. But we need to look at all of you. We do a very thorough objective evaluation, and we have a very trauma-informed approach to our assessment, meaning we're going to explain everything we're going to do in our assessment and treatment, get your consent, which means explaining what the benefits and risks are, making sure that you know you can withdraw your consent, and what your alternative options are if that part of the assessment or treatment is not suitable for you. Okay, you're very involved in that decision-making process. We look at everything from your central nervous system. We look at the way that you breathe, because interestingly enough, your diaphragm, your breathing diaphragm, and the pelvic floor move together. So when you take a deep breath in, your diaphragm comes down and your pelvic floor relaxes. So the way that you breathe will affect your pelvic floor muscles. Also, it's the fastest way into calming your nervous system, so it's really good. I had to take a few deep breaths before I came up here just to make sure that I'm zen and cool to present today, right? We look at all the global contributors, so we look at the way that you walk, your overall strength, things that, again, can contribute to specifically your pelvic floor, including your posture and your connective tissue. And if you're not sure what I mean by connective tissue, I mean everything above the muscle under the skin. So you might find your physiotherapist kind of rolling your skin, and there is a connection to the connective tissue and the organs inside. they actually communicate with each other. So when you have pain in your viscera or an organ, you could get restrictions in the connective tissue. So working on that can help some of the pain internally. So we're here to talk about the pelvic floor muscles. So without further ado, let's talk about them. Everybody has a pelvic floor. These muscles start from the pubic bone from the front, and they go all the way back to your tailbone, and they have lots of different important functions. One, they support your organs. So in this case, your bladder, the uterus, and the bowels. They go around every opening, so your urethra, the vagina, and the anus. So they contribute to your continence. They have a sexual function. So if you want to insert anything into the vagina, which is right here, these muscles need to be able to relax and have the flexibility for that to be able to happen. And they also have a stability function. So now we're getting really to the core of it, and I like how Elise had up the picture of the hand. So I'm going to get everyone just to go with me with this example, because every muscle in your body has a state. It could have a state of increased tone or decreased tone. So if you touch this part of your hand, this is normal tone. That's what we want muscles to feel like, even in your pelvic floor. But if you pinch between your index finger and thumb real hard and touch that, that's increased tone. So that increased tone could contribute to some of the pain that you're experiencing. So, if you get tension or tone in this area, I might get some tension and pain. I might even get neck restriction or a headache. The same thing can happen with your pelvic floor muscles. So if you have increased tone of your pelvic floor muscles, they can contribute to the pelvic pain you're experiencing, pain with any sexual activity, and even pain, urgency and frequency. So urinary symptoms could also be attributed to it, and constipation. Remember how I said these muscles go around the opening? In order for you to be able to urinate and have a bowel movement, these muscles need to have the proper length and release so that you can have it without pain and straining. So we really, as physiotherapists, work with you to know where these muscles are in space, that awareness of making sure that they're not tense. Because if I was to stand here, you'd say, Nellie, drop your shoulders. You're going to get some tension in your neck and shoulders, and that might give you a headache or some shoulder pain later, right? So we really want to teach you how to have an awareness of where these muscles are in space. But we need to know what is driving that muscle tension. And that could be in lots of different things. It could be your nervous system, it could be fear, it could be posture, it could be past experiences. It could be even the way that you're breathing contributes to it a bit. We might teach you some stretches to do locally or globally to help with the length of these muscles. We may even use very gentle manual therapy techniques if you're comfortable. And when we do our assessment and treatment, with your consent, you're properly draped. We move really slowly and explain everything. We don't want to be a threat to your nervous system, or else the muscles are going to tense up. But we have manual therapy skills that have evidence in the research to help you identify where these muscles are and how to release these muscles. So we may even give you products to help you do some of those treatments at home. And in the red, I just wanted to highlight, with a short period of time, that I was just really focusing on the pelvic floor. As pelvic health physiotherapists, I already mentioned we look at you as a whole, but we do lots of things, including education, addressing the nervous system, giving you strategies to improve your bladder and bowel symptoms through behavioral modification and various exercises. And of course, it's really important that we collaborate with other members of your team. Thank you very much.
Thank you, Nellie. Next up, I'm pleased to welcome Dr. Tanya DeRena. Dr. Tanya DeRena is currently the medical director of the Toronto Academic Pain Medicine Institute, TAPME, which is the only single comprehensive interdisciplinary academic pain program serving as the hub for chronic pain care in Toronto. Please welcome Dr. Tanya DeRena.
Thank you so much. Thanks, everyone. I was asked to explain pain and chronic pain and how it ties to what's going on in your brain. So The formal definition of pain is that it's an unpleasant sensory and emotional experience. So it's both a sensation and an emotion. And it could be associated with actual tissue damage or the potential for tissue damage. So you can even perceive pain when you think you might be getting hurt, not when you're actually getting hurt. So it's pretty interesting, it's pretty powerful. And chronic pain is what I manage, and it's pain that's been longer than 3 months. And it's kind of an arbitrary number, 3 months, because it takes 3 months for tissues to heal. So if you've had surgery or you've had an injury, it takes about 3 months for everything to heal. And then if you're left with pain, the pain then becomes part of the disease. It affects 20% of the population, which is huge. And to me, that anything that affects 20% of the population is like a public health emergency that no one's doing anything about. But it is huge. And when I listen to people who are in pain who come to me, what I hear is that they're being warned of something threatening and they feel like they're in danger. Because that's what pain is there for. Pain is there to tell you that something's threatening you. And so that's what I hear. There's a few more layers to the definition. Pain is always a personal experience, and it can't be inferred solely from the activity of sensory neurons. It's through people's life experiences that individuals learn the concept of pain, and a person's report of an experience as pain should be respected. There's a huge financial cost to people who have chronic pain, and there's also the emotional cost. And so people who have chronic pain are 50% higher risk of committing suicide. And that's 400 people in Ontario per year who commit suicide because of chronic pain. Acute pain and chronic pain is different. Acute pain is good for us because after you've had surgery, you're going to have pain, and it's supposed to tell you to rest and kind of protect the injury and heal. But chronic pain is actually maladaptive. It keeps going even sometimes when the tissue has healed. And so it's maladaptive because it makes you have pain behaviors as if you're having acute pain. So the way I can kind of explain it, I'll tell you using a cooking analogy after. In 2022, the WHO announced that chronic pain is formally a disease, so it now forms part of the ICD, which is our collection of diseases. So chronic pain is now recognized as a real disease. And so I use a cooking analogy, which is sad because I don't cook, and I think it's my mom coming back from the dead and making fun of me. So let's pretend you're cooking on your stove and you're not paying attention, and you have a bit of a fire breaking out. Pain is there like a fire alarm bell to say, hey, like, make a big deal out of this because you're being threatened. And if you don't call the authorities, then something really bad might happen. But chronic pain is sometimes referred to as pain that keeps going even when it shouldn't. So even if there's no more underlying disease, things have gone into remission like cancers, people can still have pain. And so it's basically like a broken fire alarm bell or a really overly sensitive fire alarm bell. And it makes you think there's a fire. So even if you try to use the toaster, the fire alarm bell goes off. And no one really focuses too much on the broken fire alarm bell. When you call your repair person or go see your family doc, they basically just focus on the stove and looking for reasons why you had a fire. And that's good, but sometimes we can't always figure them out. Like, I think medicine is really good at figuring out fires that can kill you, but fires that make you feel like you're dying slowly, we're not really good at figuring that out. And so you'll be waiting in waiting rooms, kind of waiting to figure out what started the fire or where the fire is. And sometimes you'll be waiting on another list to get a specialist's opinion about, taking a deeper look into the stove. But all this time you stop cooking, and that's a big issue for a chronic pain doc, is that you've stopped using your body like you should. And medicine really focuses on the stove, and that's good, but sometimes we need to take a look at the fire alarm bell too and make sure that that's okay. And sometimes the treatments don't always fix the broken fire alarm bell because they're more targeted towards the stove. And some people go as far as to have the stove removed. And then I'll see them and they'll still have pain because of the way pain is mapped out inside the brain. Your brain tends to make a very big deal out of pain in your pelvis. There's a few theories as to why that is, but it's probably from an evolutionary perspective. If you're being threatened in the pelvis, that's where your genitals are and your genetic makeup. So your brain is probably there to protect that area. So in order to help manage people with chronic pain, we try to teach them how to quiet that alarm. We try to teach you that sometimes, even though it feels like you're on fire, and people are telling you, oh, I couldn't find a fire, congratulations, like they told Skylar, which is probably one of the worst things you could hear because you feel like you're on fire. The idea is to educate, most likely physicians, but us too, that, sometimes you don't need a big fire to be happening for you to have a lot of pain. And sometimes it's managing expectations that you need a collection of things to make your pain better, not just one thing. And a lot of it is about teaching people how to reduce the fear, because when we feel like we're on fire, we're going to panic, right? And teaching people coping and sometimes distraction is also a great part of therapy. We teach people to use their stove and love their stove, because it can be easy to hate your stove if it's giving you a lot of pain. And we also know chronic pain as it stands now doesn't really have a cure as it stands now. And so there's lots of hope as it becomes more in the mainstream. We can find a way to help people manage. But for now, we try to focus on non-pharmacological therapies, using strategies to help people control the things they can control to quiet the alarm. We don't really have any magic pills. There's a few pills that we use, and unfortunately, like your experience, we have to try a lot of them before we get the right one. And sometimes cannabis is the answer. Sometimes, I hear people doing a lot of really interesting things, and I learn so much from my patients about what they do to manage their pain, so we collect it and put it in a little booklet. We also have to look at factors influencing pain. I always remember that people are telling me they're being threatened. They feel like they're in danger. And so really helping people get through that about what their pain is. And it might not be killing them even though they feel like they're dying. And understanding all of the outside things that make you feel more pain. So we know poor sleep and diet. If you look at babies, right? If a baby doesn't sleep well, no one's sleeping the next day. You can't do anything the next day. And we're just big babies. I know I am. If I don't get enough sleep, I'm not going to function the next day. And there's no way somebody who's got a chronic pain condition can function well if they haven't slept the night before. And so we really look at these type of things. What are the things we can control? Your diet, sleep, your anxiety, depression. And anxiety and depression are concomitant disorders with a lot of chronic diseases, not just pelvic pain, not just chronic pain, but a lot of chronic diseases, diabetes, hypertension, COPD. They also have a lot of underlying anxiety and depression. I also wanted to make a comment on the factors influencing pain. So I tell people, okay, you're telling me you're being threatened and you're in danger. And some people are really good at perceiving threat and danger because they've felt it their whole lives. And so this little cartoon has maybe a cisgendered male who doesn't understand why the race isn't the same, because they probably haven't been threatened like somebody who's maybe a biracialized person. They feel threatened all the time. So they're not perceiving threat the same way. So pain is different for everybody. I also wanted to make a comment about adverse childhood experiences, because we know that people who have chronic pain conditions have a lot of adverse childhood experiences. And the medical community is slowly starting to tie this together about what happens when a kid has a bunch of adverse childhood experiences. What happens to their pituitary hypothalamic connection? What happens to their adrenal glands? How much cortisol they're secreting? Because we're starting to see people with a lot of autoimmune diseases, a lot of pain diseases, a lot of chronic diseases who've had complex childhoods. And so what's happening when we're young and we're growing and our organs are growing? I just proposed a few things that you could look up if anybody has some pain and is looking for resources. My website has something called Pain University Online, and it goes through different types of management for pain. We also have a connection with Ontario, Self-Management Ontario. It's a progress over pain. It's a workshop you can do with other people who have pain. They'll have a variety of pain, not just endometriosis, but it'll go through skills, teach you how to make SMART goals, teach you how to kind of cope, creating little strategies about when you have a flare. It's always good to have a little toolkit to say, okay, if I'm having a flare, these are the 6 things I know are going to make me feel good. Because when you have a flare, it's not a good time to figure out what to do in a flare. So it's always good to kind of plan ahead on what things can make you feel better. Power Over Pain Canada is a website which has a bunch of workshops, big collection of workshops and information. There's also, through Wellness Canada, some counseling. So if you need peer support or counseling one-on-one, there's a connection to some one-on-one peer counselors there. So people who have pain who have been trained to do counseling. So there's another tool to use if you're having pain, and that's it.
Thank you so much, Dr. Durena. Next up, we have Dr. Charles Argoff. Dr. Charles Argoff is professor of neurology at Albany Medical College, director of the Comprehensive Pain Center at Albany Medical Center, and director of the Pain Management Fellowship in Albany, New York. Please welcome Dr. Argoff.
Thank you so much for inviting me to participate. Sorry. And I don't, what I'm about to go through is a different way of looking at what many of you have experienced, and it's not meant to mean that we know all the answers, and I'm always humbled by how much we need to know more to be able to help people who we see, and also so I don't want to, we're excited about some of the progress that we've made, but we realize there's a lot more work to be done. What I'm going to focus on is just some of the observations we've made in seeing Dr. Day and I have had the, I think, pleasure, Dr. Day, of seeing people together from a urology and neurology point of view, and some of our other colleagues in OBGYN are now joining us as well in a combined patient appointment or a clinic. And one of the observations that we made several years ago was that many people who presented to us with pelvic pain or complex pelvic pain also had pain and other complaints in other parts of their body. And so an individual might have pain related to GERD or migraine or fibromyalgia or temporomandibular joint pain, or unexplained ringing in the ears or other complaints. And so over time, we developed this checklist, and this is found in Dr. Day's publication, facingpelvicpain.org. And we find this extraordinarily helpful to help understand what else might be happening to somebody who is also experiencing complex pelvic pain. Because what if the pelvic pain is being experienced in the endometriosis and other complaints are being experienced in the context of another disorder? And so that was kind of our hypothesis. And we are in the process of putting together a new manuscript that shows that over 50% of people who present to our center actually have a neurological problem that they hadn't known about. And so we found that different rheumatologic disorders coexist with chronic pelvic pain as well. But one of the additional discoveries that we made is that we had this sense that perhaps if someone is experiencing a more widespread problem, including fibromyalgia, lower back pain, migraine, and complex pelvic pain, there might be a way of understanding from a diagnostic neurological point of view what else might be going on, and could there be a commonality? And so there is an entity known as small fiber neuropathy. It's named after the diameter. Our nervous system, as you may know, is our nerves are like wires, and the different wires have different diameters and different functions. The small diameter nerve fibers, which basically escape a typical examination, and escape, for those of you who've ever had an electrical study known as an EMG or a nerve conduction study, they're not tested. And so a person with a small fiber neuropathy could come to a, the healthcare provider's office, a physician's office, and be told that everything looks normal because you're not really assessing for that. It's not a really good way to assess for small fiber neuropathy at the bedside or in an office setting. But we had this sense that people having difficulties with urination, pelvic floor dysfunction, sexual dysfunction, in the context of also experiencing endometriosis, fibromyalgia, and other complaints, might have an underlying small fiber neuropathy. So you see on this slide our results, that when we can ask 39 people consecutively, and now we have more people who have done this, we saw that 64% of these individuals, of people who we were seeing, had a biopsy. The way to do this is through a skin biopsy for small fiber polyneuropathy. The prevalence in the world, the only data that we have, is 12 out of 100,000 people. So 12 out of 100,000 people is what you see in general, but people who have complex pelvic pain, 64% of the time may have this condition based upon these data. And this was published in 2019. And this is what a nerve fiber density evaluation looks like. You see on the left side, the little squiggly lines are the small nerve fibers in the skin, and that's in a normal person. In this panel B, you see a reduction in those squiggly lines, which reflects a person who has widespread pain, but a reduced number of these fibers. And there are many symptoms. If we look together at the symptoms on the slide, we see that not only are there abnormalities of sensation, pain, symptoms varying throughout the day, but also what we call autonomic dysfunction, which and the autonomic nervous system is what regulates sweating, urinary function, gastrointestinal function, cardiovascular dysfunction, and with respect to urinary dysfunction, it's not only bladder, but it's also sexual dysfunction. So we have been working together, not only certainly helping people to be as symptom-free as possible. And Dr. Renner, the last discussion is an excellent approach to trying to manage pain in this setting, because we don't have a magic pill or a magic bullet. But identifying this underlying disorder has really helped us to understand what people are experiencing and work together to try to understand, is there a cause? So here you see a list of causes. We have been able to identify new diabetes in people who didn't know they were diabetic, people who have vitamin B12 deficiency, autoimmune disorders, previously undiagnosed gluten celiac disease. You can see there's a wide range of factors to look for, and we do look for these things. But also, please look at the bottom, the last bullet. And this is, I have to be honest, and of course I'm going to be honest, but sometimes we don't have a cause. And in between 30 and 50% of people who are evaluated, we don't have a cause. And so we call that in the medical world idiopathic. And small fiber neuropathy may be a condition that results in what we call sensitization of the nervous system. Dr. Renner kind of described ways to reduce that sensitization through cognitive, behavioral, and other strategies. But essentially, if you have a sensitized nervous system, everything is experienced in a more augmented way. Normally, we can inhibit the way we experience different sensations, but in a nervous system that we believe occurs with people with small fiber neuropathy and other chronic pain states, there's a variety of reasons why, both in the periphery, means outside of your spinal cord and brain, as well as within your spinal cord and brain, things are augmented. It's not normal to have these sensations augmented. And so we're kind of working furiously to figure out a way, either through cognitive behavioral approaches or other approaches, as a community of people really trying to work together to address this, to dampen this oversensitization. One of the consequences of a sensitized nervous system and a reaction is to catastrophize about the pain, which is understandable, but addressing the catastrophizing, and I think Dr. Renner pointed this out, can really help, has been shown to be able to help dampen the pain, and is really helpful when we work together collaboratively. So in summary, we do think that complex pelvic pain, and I'm sure you know this, but I just want to emphasize that it is absolutely complex, and we really need to be mindful of the different diagnoses that underlie it. We have demonstrated pretty definitively that small fiber neuropathy is prevalent in people with complex pelvic pain, and identifying it may lead to having all of us help each, we can all work as a team to help people who are experiencing complex pelvic pain in this setting. And central sensitization is important for the experience of pain. And as Dr. Renner so nicely outlined, and I think we, of course, all of us, and Nelly did as well, all of us we're all here to try to offer a multimodal, multidisciplinary approach to help people with this disorder. Thank you very much.
Thank you so much, Dr. Hargoff. Next up, we have Dr. Lemos. Dr. Lemos underwent his medical graduation as well as his gynecology, urogynecology, and MIS training and PhD in gynecology at the Faculty of Medical Sciences of Santa Casa de Sao Paulo, Brazil, and attended a fellowship in pelvic neurodysfunctions by the International School of Neuropelviology in Zurich, Switzerland. As of January 2017, he has been recruited as associate professor at the Faculty of Medicine of the University of Toronto, where he has started the Pelvic Functional Surgery and Neuropelviology Clinic at the Department of Obstetrics and Gynecology of Mount Sinai and Women's College Hospitals. Please welcome Dr. Lemos.
Thank you, Katie. Thank you very much for organizing this with the ICS. It's a great opportunity for us to exchange ideas and spread important concepts. I think everybody who spoke before me, because you've laid the ground for me to touch, I think, the most controversial topics on endometriosis care. So starting with Skylar and Kim and the description of your experiences and all the mechanisms of pain that have been described by Dr. Day, Dr. Fagani, Dr. Direna, and Dr. Argoff. I think we can understand better a bit of how endometriosis causes pain and what we can do to treat it, right? So, as you now all know, endometriosis is characterized by the presence of cells or tissue or implants that are similar to the ones on the video. So that is how the endometrium work. Every month, when the ovary starts producing estrogen, the cells multiply, and then that layer thickens. Then after ovulation, the ovary starts throwing estrogen and progesterone on it, and then in response to estrogen and progesterone, it stops multiplying the cells, dividing the cells, and it starts producing nutrients so an embryo can come and implant. And if that doesn't happen, the ovarian production of hormones goes down, the follicle degenerates, and that layer sheds and bleeds every month as the menstruation, right? So the implants of the tissue that are similar to that is elsewhere, will respond to hormones the same way. Therefore, there's always cyclic bleeding, and blood is the cause, is a highly irritant substance to the body. Every time it's out of a blood vessel, it will activate the pain receptors very intensely, right? So that's how endometriosis creates pain. It will drop blood close to pain receptors in areas where it's implanted, right? What will it cause? Well, there are two kinds of pain that is caused by endometriosis. One is the direct pain. The other one is the secondary pain. So direct pain are the pains that are caused exactly by this mechanism of blood irritating those pain receptors that I just explained to you. So that being said, the typical endometriosis pain pattern is menstrual cramps since the first period and progressive throughout the person's life. 2, pain with deep penetrative intercourse, so what we call deep dyspareunia, and pain with ovulation. So these are the 3 kinds of pain that endometriosis causes. It may also cause some organ-specific pains depending on where it's implanted. So, for example, if endometriosis infiltrates the nerves that innervate the bladder, it can cause bladder pain. Or if it infiltrates the bladder, it can cause bladder pain, urinary urgency, and frequency. Or if it infiltrates your sciatic nerve, it will cause pain going down the back of your leg. Or if it infiltrates your levator, your pelvic floor muscles, it will cause gluteal pain, sometimes anal pain, and so on. But those 3 are always present. Okay, so that's the hallmark of endometriosis. Another thing that is important to understand is the pain is usually during those periods of the menstrual cycle that I have just mentioned. During the menstrual bleeding, worse on the first 2 days in general, and then progressively better. Then it usually disappears. The pain is triggered again around ovulation, then it usually disappears, and then again when the period comes. Exactly as Skylar has described, it starts like that, and then there is a tendency of chronification. The chronification that happens after that is what we describe as secondary pain. So all those phenomena that Dr. Fagani, Dr. Direna, and Dr. Argov have described, they all can, in theory, and that's our understanding at this point, be triggered by the chronic pain stimulation, like the repeated pain stimulation by endometriosis. So at some point, because of every month, twice a month, right, during the menstruations and during ovulation, that pain repeating itself, we believe that the nerves start to grow peripherally and multiply. We know all those increased densities have been described everywhere in the endometrium and the uterus and the pelvic peritoneum and so on. And the belief nowadays for that explanation of those fibers growing and spreading is that happens in response to the continuous pain stimuli in people who have a genetic susceptibility or sensitivity to pain. So basically, one way I explain my patients is, have you ever noticed how much math they teach us in college and high school, and how much of it we use? Have you ever figured why they teach us so much math? It's not for you to use a second grade equation on. It is for you to improve for us to improve our logical thinking, right? So same way as studying math makes us better at logical thinking, feeling pain, unfortunately, makes us better at feeling pain or more susceptible to pain. So that is one of the reasons we fight so strongly for early diagnosis, because we want to avoid that repetition, right? But it's also very important for us to understand that, because once that cycle has established, that process has established itself, it becomes self-sufficient. So treating the endo alone is not going to solve the problem, right? So let's understand. So once we all agree with that concept, I think we got to go towards the options we have for endometriosis. So basically, the options of treatment we have are, one, we can reduce inflammation, and that's essential. we reduce inflammation with anti-inflammatories that we can prescribe during ovulation and menstruation. We can then reduce inflammation with diet, specific anti-inflammatory agents. Naturopaths are really good at helping us do that. And then once we go into so that would be the first line treatment. We can reduce the overall pain mitigators, as has been already, pain mediators that the secondary pain elements that have been very well explained here. And then specifically to the implants, we can reduce their biological activity by hormonal levels or by operating on them, right? So with hormones, we have basically three options. Option one is the regular birth control. It is not wrong to try birth control, and it is, unfortunately, to this moment, a trial and error thing. We're very hopeful that we'll get a moment where, we'll get soon to a point where we can do pharmacogenomics. So basically, you have a blood sample based on your DNA sequence. You know which drug will work best for each person, right? So there's a lot of research going on for this. So that is going to reduce the trial and error that you all know how painful it is. So, but that's the way we are, the point we are now. Unfortunately, for hormonal management, we need to go with trial and error and see how our patients respond to that. And it's 6 months for each hormone. It takes, every time you prescribe a hormone, it takes 3 months for your body to adapt to it, and then 3 months for you to observe the response. So every time you prescribe something, you're going to have side effects for the first 3 months. We always tell patients, okay, try to power through that, because after 3 months, that's how we're going to see how your body is going to settle with that medication. So we can do combined pills, which are the ones that have estrogen and progesterone. So by adding progesterone right early in the process, we will reduce that thickening of the layer of the endometriotic cells, and we'll reduce the amount of bleeding that happens, or even preferably block the bleeding. So hormonal treatments will not block the progression of the disease. So that's another important concept. And that's something that is sometimes mistakenly described there. The second option we have is progesterone. So we can give progesterone-only medications that can be injectable or oral. And basically, they do the same thing. It's, again, a trial and error process. Some patients will respond better to combined contraceptives. Some patients will respond better to progesterone only. The other option we have is to completely block the ovarian activity and then use what we call an add-back therapy, which is made with estrogen and progesterone to keep the hormonal levels steady and try to avoid those bleedings. So that's the concept behind medical management. And it is thought to sort the endometriosis problem. It is expected to sort the endometriosis pain-related symptoms between 30 and 60% of the patients with pain. It's important to highlight that not everybody has pain with endometriosis or a strong pain with endometriosis. We know that about 10% of the population has this condition, and not everybody has pain or infertility, right? So we're still trying to learn how this happens, but for those who have pain, the expected is that 30 to 60% will have their symptoms brought to a manageable condition with those hormonal approaches. Again, once you have if you have a hormonal treatment, it is also important to see with imaging if you did have if you do have it, deeply infiltrating endometriosis, and where it is, because we need to monitor, especially for the kidneys, when you're doing long-term treatment for endometriosis, because, as I just said, it doesn't, like the hormonal treatment will block the symptoms, but it will not block the progression of the disease. And another line of research that is going on with endometriosis nowadays is predictors, genetic predictors or biologic predictors of progression. We know that 50% of implants will progress, but we know that also about 25% will regress, will shrink, and another 25% will remain perfectly stable for the rest of the patient's life. So, and unfortunately, at this moment, we do not have a way to anticipate that, to predict that. It would be awesome if you had a test and said, okay, so that person has an endometriotic lesion close to their ureter, and it is going to progress. So let's operate before it gets into the ureter and the surgery is much bigger. Or this person has a big nodule, but we managed to sort their symptoms, and their disease is not going to progress, or it's going to be stable. So then problem solved, right? But we don't have that, unfortunately. So we have to monitor that with imaging, because ureteric involvement can be silent, and we need to be vigilant for that. And that takes us to the point of when we perform surgery. So there are basically 6 indications for surgery. The first one is the one I already told you, when you have ureteric obstruction, because that can cause the loss of renal function. It is rare, but it can happen, and we must be vigilant for that. Second one is when you have bowel obstruction. So the main symptoms for that are the stool coming, we call it in the tape format, so they start to become thin. There is the bloating, is abdominal distension, not that bloating that happens around ovulation and menstruation, but a more constant and progressive distension. So these are signs of bowel obstruction, right? So we're vigilant for that. If there are bowel nodules and those progressive symptoms, that's one of the situations that we as physicians recommend surgery. Then the third situation that we as physicians recommend surgery is when you have a nerve entrapment, because you know that once a nerve is entrapped, the nerve will degenerate. So basically what I'm telling you is physicians recommend surgery for endometriosis when there is a risk of the loss of function. The other 3 indications are when the patients tell us that they need surgery. So the other one, the first one is infertility. So if a patient has endometriosis and deeply infiltrating, deeply infiltrating endometriosis and infertility, and their fertility specialist thinks that the endometriosis is one of the factors causing their infertility, then we have an indication for surgery, because, well, you cannot control, and especially if they have pain, because then you cannot control pain and promote fertility, because you're necessarily blocking the ovaries for the pain control, right? So that's one of the situations we will suggest surgery. The other one is when the medical management has failed. And the 6th situation is when the patient is symptomatic and do not want to try hormonal management, or do not want to proceed with that, but prefer surgery instead of going through the trial and error process. So these are the 6 indications we have for surgery. When not to operate, that's also a very important point, and it's sometimes much more difficult to know when not to operate and when to operate. But when the main contraindication for surgery we see is false expectations, because false expectations or unrealistic expectations are what is associated with a high level of failure. So, as I said, surgery will only work for those symptoms that are directly, the first group of symptoms that I explained to you, those that are directly associated with blood stimulating the pain receptors there. So that's the only thing that surgery can help with. And then if the patient expects other symptoms to go away with the surgery, that's a very bad prognosis factor. Another bad prognosis factor is our patients that are out of work. We usually try to work with them to gain their self-efficacy before surgery because of all of the chronic pain mechanisms that Dr. DeRena has explained. Patients that are not working at the time of surgery, they tend to have much poorer results than those who are working with the same degree of disease and the same degree of pain. So we usually try to revert all of that before we proceed with surgery. Also, chronic opioid use. This is dramatic. Those who are relying on opioids or being prescribed opioids for pain control have the worst results of all. Our data shows that the success rate is 2/3 lower in those patients. So when you're talking about, to give you numbers with excision surgery, our success rate when we are sparing the uterus is between 70 and 90% at 2 to 5 years, meaning no recurrence of symptoms at 2 to 5 years. 70 to 90%, sorry, when we're preserving the uterus, 60 to 80%. When we remove the uterus, 70 to 90%, right? So these is the mid to long-term success rate of excision surgery. And in patients that are using opioids chronically, this success rate will fall to 30 to 40%. So everything, all of those changes need to be reverted before we go ahead with surgery. The last part of this talk is how to do surgery. And to understand how to do surgery, we need to go through all the theories because each strategy, surgical strategy, is based on the surgeon's faith on the pathophysiological, the origin of endometriosis. It's not been proven, but there are a few concepts or a few theories that explain the appearance of endometriosis. The one that got most diffused, most widespread, is the retrograde menstruation. And that happened because Sampson, who was the one who described endometriosis as we see it today, back in 1927, observed that there was retrograde menstruation. He observed that there were endometrioid implants in the peritoneum, and that the cells in the retrograde menstruation could be grown on a cell culture. So he thought, well, probably these cells are coming out of the tubes, implanting there. It was a high prevalence disease. He started disseminating the concept and explaining people why people had those menstrual cramps and all those symptoms and so on. And the concept, the theory spread with that. And then people started noticing endometriosis on the nose, ears, lungs, so on. And that mechanism could not explain how could endometriosis be on the lungs if it's coming from the tubes and then getting implanted there. So some other theories came to explain that. So they developed the theory of lymphatic dissemination, so that endometriosis could go through the lymphatic system based on the fact that we do find endometriosis in lymph nodes in the pelvis, and some other that it would go in the bloodstream. It could infiltrate and get into the bloodstream and then get implanted far away. There was another questioning about Sampson's theory, which was, look, 30% of people assigned female at birth have retrograde menstruation. So why only 10% will have endometriosis? And then they developed an immune theory and there's lots of studies showing that the immune system works differently. Now we know that it's probably because of the chronic inflammation. But because of that, the ability of cleaning those cells was diminished, and that's why those implants happened. They tried to develop animal models to show that. They had developed with macaques a model where they would block the cervix and to cause retrograde menstruation. They would see what happened, and then they would knock parts of the immune system to try to recreate, and they could only recreate superficial disease. So on and on, people, endometriosis specialists realized that it made no sense to keep on insisting on a way to explain Sampson's theory. And the theory that I believe, and the theory that is gaining more and more space, is that everybody who has endometriosis was already born with their endometriosis. So basically, we all come from one embryo cell, right? And that cell multiplies and differentiates itself in different tissues. So this theory, which is the theory of the coelomic metaplasia, says that the endometrial cells that were supposed to develop only inside the uterus, during this process, will differentiate somewhere else. And that can explain everything, right? And it also, and understanding those theories is very important for the management strategies. Because if you believe that retrograde menstruation is the problem, then you believe that the problem is on the surface and you can burn it. And ablation would therefore be more efficient than what we see. But what more and more people believe on is that we're all born, and there's a very nice study from David Redwine in New York. He did this study in New York morgue, where they autopsied girls and women who had died during car accidents. So pre-pubertal females and post-pubertal, so females in during the reproductive period. And they found that the prevalence of endometrioid tissue outside of the uterus was the same on both. So that destroys the retrograde menstruation theory, right? So, and then the results of surgery are also much superior with excision surgery. Those are the numbers that I already told you. So that's what guides us, and that's why we are so aggressive with surgery nowadays. It's because we actually do believe that the endometriosis is curable. What I tell all my patients is, if you have a recurrence, what you have is not actually a recurrence, it is a persistence of disease. It was probably a nodule that was small enough that I didn't see, or I missed it, or a piece of endometriosis that flew off of my instrument while I was excising it. And that's what I believe, right? And that's what more and more surgeons believe nowadays. So I think these were the instruments that I wanted to, the points that I wanted to touch, and I think the questions can be answered during the discussion. Thank you all very much.
Thank you so much, Dr. Lemos. Next up, we have Destiny Savory. Destiny has been diagnosed with both endometriosis and adenomyosis. As a speaker, author, and health influencer, she is a triple threat. Please welcome Destiny.
Hello, how are you doing? How are you doing? I just want to see a show of hands. How many people have children here? Show of hands. Anybody who have boys? Show of hands. All right, thank you. Today is actually, as they say, Happy International So you celebrate your boys. You know, you see it on Facebook or Instagram, and you see people taking beautiful pictures with their children, right? And it's amazing that that people can conceive. But unfortunately, 2 weeks ago, I didn't have the power of consent. I didn't have that decision. At 42 years old, I decided to do the full hysterectomy because I didn't no longer want to be in pain. And I suffered with from 2017 to now. I got four incisions, thank God, through laser surgery in Canada. I'm very grateful for the doctors and the surgeons who did my surgery, brought that type of procedure here for me, because my first surgery was a full C-section cut where they removed 18 fibroids, 2 cysts, and 18 pieces of polyps and scar tissue. I went into the surgery weighing 120 in 2017 and came out 110. So imagine 10 pounds of mass coming out of me. As you can see, I identify as a she, her, a black woman. I also have, I'm hard of hearing, so I don't identify as somebody with disability, or I see myself as limitless. And even though I've been through all this, I'm here and standing telling you today that I'm just waiting to turn 43 so I can be pain-free. So tonight when you go home and you hug your children, and you hug your sons, please remember that not everybody has that type of power, the power of consent. Thank you very much.
Thank you so much, Destiny. Okay, that ends our speaker segment portion of the evening. We are going to take a quick 5-minute break, and then we will return for the panel discussion. Thank you so much. See you in 5. Okay, everyone, thank you so much. We're going to get started again. Before we get started, I'd just like to prompt everyone to go to slido.com for our polls during our panel discussion and enter the code that you can see on the screen, 2136981. Thank you. It's my pleasure to introduce Philippa Bridge Cook, a scientist working as a medical writer and scientific advisor specializing in molecular diagnostics. Her own experience with endometriosis sparked her passion for helping others who are also suffering because of the disease. Please welcome Philippa.
Thanks, Katie. So we have about 20 minutes left for this panel discussion. So we're going to try to get through a few questions, and we know we had an immense number of questions submitted online. Thank you all for your interest, and we've picked out some of the most common ones that we may not, if we don't get to them today, we will try to, our speakers have kindly offered to provide us with some written responses that we can send out to everybody after the event. So we really appreciate that. So our first question is around dealing with chronic pain, as we've heard about quite a bit today. I think we all can understand as chronic pain patients how we have to make those choices every day of like, do we keep going despite the fact that we have pain, or is it better to, you know, lie down and rest? Like for some of us, we even face the choice of should we keep working, or is our pain so severe that we may just have to stop working? So I think we will start by launching the poll and have everybody weigh in on, do you normally push through the pain and continue your daily activities and work, or do you usually rest? So please enter your answer. Okay, we've got some responses coming in. It looks like we have a large preponderance of people pushing through the pain. So, Dr. Durena, what are your thoughts as a chronic pain specialist on that question?
It's so funny because I always thought if everybody had endo, the entire world would have 10 days off work a month. But that's unfortunately not the case. And so what we teach people at our clinic is to have a plan so that you could take frequent breaks and try to have a plan of what you're going to do and what you need to do in order to get through the day. Like Nusalio said, unfortunately, people do have to work sometimes just to pay the bills and keep a roof over their head. So people do push through the pain, and that's the reality. So it's kind of a question about, do you have the luxury of kind of not pushing through the pain? Not a lot of us do. So the idea is if you have to do this, to give yourself a plan of what to happen if you have an acute pain flare, if it's too painful to go to work. Having a supportive family physician sometimes helps. Not a lot of people have that, but having a supportive boss and telling them, listen, I have this condition, saying that you need rest during the day, small breaks, having, if your company allows it, having an ergodynamic assessment, so an OT can get you a sit to stand desk or table, doing things, advocating for yourself a little bit at work so that you don't have to push through the pain, so that you do have some breaks. So the idea is to be prepared to advocate for yourself, to have those rest periods. And so I guess my answer is, it's not good to push through the pain, but most people don't have the option of not doing it, right?
Thank you. And Dr. Fagani, we would also like to hear your opinion as a pelvic physiotherapist.
I mean, I'd love to know how we can prevent the flare. So is it that, you're working long hours and maybe you need to have more frequent breaks before it starts? If you can find that threshold before it starts and implement those things. I totally agree with Tanya, and having a strategy, whether it is getting up, going for a walk, using a hot pack, maybe lying down. But I think we need to listen to our bodies. Sometimes we don't have an option and we need to push through. There are many advantages to keep going. Like I think you use the analogy, like use your stove, right? So, and that's part of it. Like part of our activities of daily living include work, but we need to be gentle on ourselves as well.
And I'd like to ask Skylar to weigh in. And what are your thoughts in terms of what you normally do and how does that affect your daily life?
Well, I am not very good at resting. It's something I have to work on, but I find me like push through the pain because it's been ingrained into like my brain, all our brains, that we have to constantly be productive. If we sit around at home and do nothing in pain, we're considered lazy. Or like, I feel like society has told me like you have to do stuff. If you don't do something, like you're a waste of space. Even though you're not. If you don't do stuff, rest, it's good. But I have that ingrained in my brain that's something that I have to work on. Be like, it's okay to take breaks. It's okay to use mobility devices. That if you continue to push through your pain, it might cause a flare-up. So taking those breaks and taking those times to rest and breathe is perfectly good and okay. And to not continuously push through the pain till it gets to a point where you're like me laying in bed going like a spider going on his back going like, oh God, I can't move, send help. So rest when you can and if you can.
Thank you. Great advice. Okay, we'll move on to the next question. So if we could go to the next poll. What have you tried for managing your chronic pelvic pain? And this is, we're talking about things outside of endometriosis management. So chronic pelvic pain sort of management strategies, nerve block injections, oral medications, pelvic physiotherapy, cannabis, other complementary medicine approaches like acupuncture, naturopathic remedies, diet modifications, and regular exercise. Big list of options there. We'd love to hear what you've tried. I'll give people a second to answer. Okay, so it looks like actually the majority of people have tried almost everything that we've got here, which as a patient myself, I'm not surprised to hear that. Pretty sure I've tried them all too. So I'd love to hear from Dr. Argoff. I think he's still online. What his thoughts are on managing chronic pain. No, not online anymore. Okay. Then let's go to Dr. Day.
Yes, Dr. Durena will be able to help as well. I mean, my approach is I really conjure a lot of my colleagues. I really involve my colleagues to help me, including Dr. Argoff, and we will take a multimodal approach. So my understanding is that to keep the body moving, all of the natural endorphins, those are very helpful. And then, of course, you know, diet, exercise, avoiding irritants. I depend heavily on my colleagues in pelvic floor physiotherapy. Often the pelvic floor muscles are not the only problem, but they are reacting and they're contributing. And medications, when we start suspecting neuropathic pain, it gives us the opportunity to start using neuropathic pain medications, and that can be very helpful. And I really think it's important to have a plan and a backup plan. So when people are stuck and there's nothing available to help, it can be extremely anxiety producing. And I think that fear makes the pain worse. So I really like to try to provide a plan and a backup plan too.
100%. I think no patient wants to be sitting in their doctor's office and hear there's nothing I can do to help you. I mean, we all know that sometimes, you know, maybe that particular doctor isn't the right specialist. And so then we want to hear, like, we will send you to somebody who can help you, right? Mm-hmm. But sort of saying, this is the end of the line for you, like, that sounds pretty depressing. So Dr. Durena, would you like to add anything there?
All right. So I don't want people to underestimate themselves, like the power of themselves either, because I think as a society we've gone to giving powers to pharmaceutical industries and other people, and you have your own internal pharmacy. That's how the pharmaceutical industry has like made money off of your receptors. You make chemicals in your body to activate receptors. You make your own dopamine, you make your own opioids, you make your own cannabinoids, you make your own stuff. That's why you have receptors that exist for these medications. So doing things that release your own internal pharmacy, to me, like telling people you love them, trying to smile, trying to laugh, those things are just as good as oral medications. And the thing is, they're a lot harder as a physician to sell. And I just want people to kind of pay attention to that part too. Because a lot of the times it's like, I'm always trying to figure out, what are you doing to make yourself function? And that's what you're going to do best. So like exercises, you're only going to do exercises you like to do. We all, you know, if you go try to exercise and do something you hate doing, you're not going to do it. So what do you do that you like to do? And make that a part of your regimen, right? So writing a prescription is very easy, but telling people like, you can do this yourself is a little bit harder. So I just wanted to say that, like, realize your own internal pharmacy and let's stop giving money to the big industries taking advantage of it. And I just wanted to make, that's one comment about the opioids. People are not responsive to surgery when they're on opioids because taking that pill exogenously obliterates your ability to produce your natural opioids. And so people can't control their own pain anymore. So you give them surgery, even if it might be the right surgery, their body, their ability to manage their own pain is gone because they're taking it synthetically.
Yeah, I think that's a particularly tough one for patients because a lot of times people are in like such severe pain before surgery, right? And it's like a catch-22. I mean, if you know that it might not work as well, but then you also still have to keep functioning. So, I mean, I hope that my hope as a patient would be that the working with your doctor ahead of time to like find other strategies to manage your pain if endometriosis surgery is what you want to do, that would work. And I want to ask Stacy to weigh in on this question and if you've tried any of these strategies and what worked for you.
Okay. So I would say I'm very like active in I did fitness and all that stuff. But in terms of what would I say? I think I've done that whole list except for acupuncture. Right, and I did find after pelvic floor physiotherapy, I did see a reduction in pain, because I also during the surgery I realized that I was told that I have adenomyosis, the cousin, so now I'm taking approach also with health and diet, and I'm doing it naturally. I've successfully weaned myself off all medications, and in surgery, I told them I want no painkillers. The doctor was like, "What?" And I'm like, "Yeah, I don't want to be prescribed. I just was on a regular Tylenol."
Stacey, have you found that at different times in your course you've needed more help and less help?
Yeah, it's like even like the pain and everything else, it's like a wave. It comes and it goes. But because I think that I built up such a strong pain tolerance that even the highest form of medication at one point didn't work. I basically had to train my brain and train my body to take it and go through it. And so I realized coming out of this surgery, I said, you know what, I'm going to go through the pain. And so 2 weeks out, I've been, like yesterday was the first day I actually felt pain-free in my life, 42 years old.
That's so amazing to hear. I hope you have many more days like that. Okay, so let's go to the next poll question. We had a question from some of our registrants basically asking what can people do at home to help with pelvic pain, and we've covered some of that with the chronic pelvic pain approaches that we just talked about, like the nerve block injections and things. But here we're specifically talking about having a toolkit at home that you can access if you're having a really bad day and that help you cope and know what to do. So do you have that kind of toolkit at home? And it looks like the majority of people in the audience do, which is great. Dr. Figani, could you suggest anything from your perspective as a pelvic floor physiotherapist of things people can do at home?
Thank you. Yeah, different things will work for different people, but trying different strategies. Sometimes there's restorative rest positions, like lying on your back and putting your feet up on a chair. Deep breathing is helpful for some people. Sometimes people find restorative yoga very helpful. Sometimes baths, hot packs, going for a walk, listening to music. Sometimes just anything that instills joy can really be helpful. Like, I love watching things that make me laugh, so I might get on YouTube and listen to my favorite comedian. So just finding something that resonates with you. I've had clients that have found different stretches to be very helpful as well.
Thank you. And so I think we can put up our final poll question, which is, so we had a question that came in, what is the best way to manage endometriosis-associated pain? So now we're talking more about like pain specifically related to endometriosis, which can be managed differently. And the options that we have here are birth control pills, progestin medications like Vizan, injectable medications like Lupron, and surgery. So this goes back to what Dr. Lemos was saying in his presentation about the different ways of managing endometriosis. So I'm seeing online with the poll that no, it's changing still. About 80% of people have found surgery to be helpful. And then it looks like for this audience, you know, Dr. Lemos mentioned in his presentation that birth control pills about 30 to 60%. And we're tending on the lower end of that range here with about 25% of people saying that birth control pills were helpful. Dr. Lemos, I wonder if you could expand a bit. I know that you've talked about all of these options, but like, is there a best way, or is it, you know, it's probably a shared decision between the patient and their doctor, but are there any, you mentioned, I think, that there aren't really any predictors of who can respond, so.
There is no best way. The truth is whatever works for that person works. So that's, the goal is to work together and try to find that, right? All of the medical management options have been studied also in long-term management, and we know how to do that in a safe way. So there's studies, for example, with Lupron or Zoladex of up to 10 years taking a generation analog, and patients that had their symptoms fully controlled. Because we all look, it sounds tempting when we're saying about, okay, we have a 70% success rate with surgery, but also we have a 5 to 10% severe complication rate with excision surgery. And then those who have a complication, 5% of our patients regret having surgery. So it is not safe, not a 100% safe option. We do the best we can, but it's important. So it's nice to keep an open mind. It's important to keep an open mind and be willing to try as many options as possible to try to find the one that works best for you.
Thank you. And I'd like to ask Kim, if she's online, what has worked for you, Kim, in terms of managing your endometriosis-associated pain?
So when I was first younger, experiencing the pain and discomfort, I was put on birth control and over-the-counter Tylenol, which helped somewhat. And for whatever reason, my endometriosis was dormant for a very long time until I started the HRT. And at that point, you know, I went back to the things I did as a young woman. heat, which has been mentioned, exercise, breathing, clearing my head, over-the-counter medications, and some discussion on opioids has been mentioned, but I have used opioids to manage some of the severe abdominal pain. What was really helpful for me was the medication that was prescribed to shrink the tissues. And then, of course, with my recent surgery, I'm pain-free now. So
That's
pretty much
wonderful.
everything that's been discussed, I've also used.
Right. I'm so
May-
glad.
May I ask a question? So, Dr. Lemos, if you have someone who has multi-system pain versus local pain, will you make different recommendations regarding surgery?
Oh, for sure. If I have a patient that has specifically those three, their main complaint are those three symptoms that I thought about, I am much more and failed a few medical management options. I'm very suggestive of surgery and in that situation. And then with those who have multisystemic pain, we're very persistent of them undergoing as much as of the other educational management strategies that we have through the TAPME Pain program. Dr. Direna will try to correct medically or with other strategies as much as the surrounding pain as she can, because when we do surgery, we are actually doing more tissue aggression. So we're triggering all those pathways, those heightened pathways that we talked about, and we can actually make their pain worse. So we have lots of patients at TAPME that felt worse and worse and worse after each procedure. So surgery is not always the solution.
Thank you for that perspective. I think it's interesting because what I've heard from our patient speakers today is that their journey has been very individual, and they've tried out different things and found what's worked for them. And then from the medical side, it seems like what I'm hearing you all say is, there's all these different options, and again, it's the same sort of thing, and your doctor can help guide you to say, like, you may be a better candidate for this or another, but we don't necessarily know. So ultimately, it's, in my mind, the informed choice of the patient on how they choose to walk that path and their own individual journey. And that's why I think events like this are so important, because as we educate ourselves about all of these options, then we are in a better place to make those decisions. So on that note, I think it's time for us to wrap up, and I would really love to thank all of our speakers today, both in person and online. And I would like to thank all of you for joining us today. And I would like to thank ICS for collaborating with us on this event, all of the volunteers who made this possible today, and I hope everybody has a safe journey home. Thanks for being here.